อนุญาตเป็นภาษาไทยนะครับจะได้ครับครับและลักษณะของคนไข้ก็คงจะเหมือนกับเมื่อกี้นะครับแต่ว่าคือคุยกันคือเราแอปโพสแบบ Palliative ครับก็ดูเรื่องdiagnosis คืออะไร disease management นะครับประมาณตัวนี้นะครับแล้วก็ดูเรื่องประเมินเรื่อง PPS นะครับ e-cog ก็ประมาณดู e-cog 0 ถึง 1แปลว่า PPS 70แปลว่าฟังก์ชันน่าจะยังมีอยู่นะครับแล้วก็ให้ดูสรุปขั้นตอนก็ให้ดูในกลุ่มเราจะมีคนอยู่ใน Cannabis Clinic อยู่แล้วก็เลยขั้นตอนคิดว่าคือมันจะเหมือนกับที่ทางกระทรวงให้ทำก็คือมี4ขั้นตอนคือ Contact Indication นะครับคัดกรองเรื่อง Contact Indication ก่อนนะครับคือถ้าไม่ผ่านจุดนี้ก็ไม่ต้องไปคุยอื่นต่ออันต่อมาก็ Indication ก็คือว่าง่ายมี Symptom อะไรที่ Cannabis จะช่วยได้หรือไม่นะครับอันที่3ก็คือ Treatment เนี่ยครับจะใช้อะไร THC CBD ซึ่งที่เรา practice กันส่วนมากคือมันมีแต่ THC มันเลยไม่มีขั้นตอนการที่ต้องมาคิดแบบที่อาจารย์ต้องสอนนะครับอันนี้คือตอนนี้มันเป็นแต่ THC อย่างเดียวนะครับแล้วก็รูทก็สปริงโก้อย่างเดียวเลยนะครับที่มาวันนี้ก็ได้ความรู้เพิ่มเติมว่ามีรูทอื่นเพิ่มเติมอีกเยอะด้วยแล้วก็เรื่อง monitoring นะครับซึ่งก็ monitoring symptom เรื่องใช้ ESAT ซึ่งเราก็ใน Palliative เราก็ใช้กันเยอะอยู่แล้วนะครับแล้วก็ขั้นตอนแรก Contact Indication ก็คิดว่าเคสนี้ไม่มีแต่ว่าที่เราจะระวังก็คือเนื่องจากเคยใช้ Cannabis เราไม่รู้ว่าจะมี risk for addiction หรือไม่นะครับตอนที่เรา practice คือจะมีอย่างของผมก็จะมีพยาบาลใส่คายที่เขามาคัดกรองเรื่อง addiction จะมีแบบฟอร์มเรื่องคัดกรองเรื่องการมีโอกาสเสพติดหรือไม่นะครับแล้วก็ดูเขามี anxiety ก็ไม่รู้ว่าจะเป็นถึง anxiety disorder หรือไม่ซึ่งบางครั้งอาจจะถ้าเป็นถึงขั้นนั้นอาจจะต้อง consult ใส่คายด้วยนะครับแต่ว่าถ้าดูโดยภาพรวมคิดว่า Contact Indication ก็ไม่น่าจะมีนะครับมีระวังเรื่อง addict นะครับว่าเคยใช้มาก่อนขั้นตอนที่2 indication นะครับถ้าดูมีเรื่อง pain นะครับมี anxiety นะครับมี2 pain นี่สกอร์4นะครับ anxiety ก็4เต็ม10ก็ดูไม่ค่อยเยอะเท่าไหร่นะครับก็เลยว่าอันนี้ใช้ประสบการณ์ที่ทำมานี่คือสรุปจากที่สไลด์ของอาจารย์สีเวียงที่อาจารย์สีเวียงสอนนะฮะที่ว่าทำให้ง่ายขึ้นว่าอาการอะไรบ้างจะใช้สารตัวไหนนะครับอันนี้มาฟังนี่อาจจะได้อัปเดตกันอีกรอบหนึ่งนะครับก็คือถ้าไปดูคือมันมี uncontrolled pain แล้วก็มี anxiety uncontrolled pain เนี่ยที่อาจารย์แนะนำไม่ high THC ก็ THC กับ CBD anxiety ให้ใช้ CBD งั้นมันอยู่ทั้ง2ฝั่งนะครับก็เลยเอารวมกันเลือก THC กับ CBD นะครับเราพอดีมีเภสัชจากการเภสัชคิดว่าอนาคตเราจะมีแน่ๆครับนะครับก็เลยเลือกใช้ตัวนี้นะครับก็เปิดตารางที่อาจารย์สอนนะครับว่าถ้าใช้ THC CBD ไตรเตรตแบบนี้นะครับอันนี้เขาอยู่ไตรเตรตคือกลุ่มจะเป็นกลุ่มคิดว่ากลุ่มนี้ไม่น่าจะมี Contact Indication อะไรแล้วก็ไม่ sensitive ต่อ THC เพราะเคยใช้มาแล้วก็จะใช้เป็นแบบ TID นะครับก็ถามทางเภสัชองค์การบอกว่า THC ต่อ CBD ของเราคือ1 ดรอปมีอยู่1 มิลลิกรัมนะครับก็เลยไตรเตรตคือเดือน1ถึงเดือน3คือ 2.5 ดรอปก่อนนอนนะครับไม่รู้จะแบ่งยังไงนะฮะอาจจะ2ถึง3 ดรอปนะครับเดือน4ถึงเดือน6ก็ 2.5 ดรอปเช้าเย็นนะครับแล้วก็เดือน7ถึงเดือน9ก็5 ดรอปเช้าเที่ยงเย็นครับก็ประมาณนี้ครับ
So for this group, they started with the assessment that this patient doesn't have any complications. Yeah. Oh, you did the translation. Okay, thank you.
That's the concentration of the product, so we mentioned that. So the objective of the patient is pain management, sleep, anxiety. And so we are facing a harm reduction case too. He was referred by his oncologist to subside his use from internet cannabis, from medical cannabis, because he is a patient still on active chemotherapy. So we decided to adapt as a high-end product, one-to-one for the less risk of addiction. And because that the symptoms are constant and ongoing, you mentioned the pain that is constant and some anxiety too. We can go with the oil to 3 times per day administration. And because of previous use of THC, we can start a little bit in a higher dose. So I was thinking of a plan of THC, CBD twice a day in the day, and to continue to use THC-rich at bedtime. But you know, the choice to use THC, CBD 3 times a day too can be a good option. Just because the patient responds well to THC for sleep, that's why we were thinking that THC can be used, can continue to be used with this patient. Actually, in Canada, we're starting with CBD oil and THC at night. So, like a bit of what I will give to the patient for teaching. So first to start the THC rich oil, so a little bit more than we will start usually. So at 4 milligrams of THC, because he was already taking supposedly THC, but we're not sure. And so the purpose is for the sleep, and during the day, the anxiety, the pain, and the nausea can be targeted with one-to-one oil that he can start. Regular doses and solid titrate. And it was discussed for sure to stop his consumption of internet cannabis, and it was clear for him that it was not a problem. And it will be advised to titrate up to maximum 1 ml per doses, and but you can stop at any time when you feel better. And if he wants to only increase the dose at night and stay on a lower dose during the day, that is an option in order to achieve a better symptoms profile.
So, some comments. First of all, if you can diversify the treatment with cannabis product, it's always better to limit tolerance. Okay, so when you start to introduce a CBD, aside from the fact that it's an harm reduction, but it also allows you to potentially maintain the THC at lower doses. It's obvious when there is anxiety, CBD is always a good idea. And now, once we normally, whenever you are in a hospital setting or you're dealing with other health professionals, just tell people to increase the dose until you reach the desired effect. Doesn't really work, because everybody will start thinking, oh man, you can take 1 bottle in 1 day, or how much you can increase. So we generally tend to advise the patient to reach the 1 ml dose. Okay. which is pretty standardized in Canada, which is corresponding for CBD between 20 and 25 milligram, okay, and for THC it can go anywhere between 10 and 20. Why 10 in the sort of balanced combination and 20 in the THC rich? Why we are looking at this dose as a limit? Because at that point we can evaluate if there is or not a response to a specific product. It's like when you are, for instance, using carbapenem or Lyrica for neuropathic pain. You reach a certain dose, like 150 twice a day, for instance, and you don't see any response or any sort of. There is no point to go to 300 BID. You are going to increase slightly the side effects without really obtaining it. The same thing happens with cannabis. So whenever, now in your situation, it may vary a bit because the products that you have a different concentration. But just keep in mind that in general, for CBD, higher than 75 milligram a day, not seeing major improvement or benefit is an indication that CBD alone is not really doing much. And obviously, because it's expensive, that would be good, for the patient not to waste more money, okay, on CBD. For the THC, we are looking again between 60 and 70 milligram a day. If we don't see oral, if we don't see any effect, at that point we need to change strategies. We have seen patients not responding to THC, but responding on CBD, okay? So if high THC dose will not work, we start, introducing CBD. Now, the way that we introduce it is to ask the patient to start decreasing, tapering the THC up to a certain point, and then starting the CBD, or adding the CBD on top. But for most patients, there is also a cost implicated, so we don't really want to then waste money. But this to give you a sense. So, and for Nabilon, when we are using the Nabilon, which is not in your case, will be at 0.5 at night. If we don't see really any effect, we start doubting that would be helpful for the patient. But, if with Nabilon, we can still go up a bit. Because, again, we are talking always of inequivalence of THC, so we still have, some room to play with the number. But just to remember again, when you get to the 1 ml of the oil, you need to start, 2 or 3 times a day. You need to start thinking, is that the product that is working for my patient? I don't know if that makes sense to you, if it's clear, or if you need clarification.
I'm wondering for this case, let me say that he has been taking THC ginger and it sounds like it's working. The insomnia is completely relieved. So in this case, when we have to consider from the existing administration of patients, and then we can, or just would like to decrease THC use, THC-rich use to reduce harm for the purpose that we will not continue from the existing use of this case.
So that, if I understand correctly, so you're saying why we need to change
Yes,
the
because
resin if it's doing,
the history record that
yes,
it's working that completely relief
yes,
for insomnia when the patient administer THC by himself
yes.
previously. So my question is, whether we have to concern from the existing administration of patient, or the purpose is we would like the patient to change from the THC rich to reduce harm, and then you change to the others.
Yes.
Like
Number one, we want the patient to use a medical grade product. I mean, if it works or not is one aspect, but you never know what you're taking. And yeah, and you know, he's taking chemotherapy, so he's immunodepressed, is you know, all potential for complication. Second, we want to have him, you know, rely not just on THC, because in the long run, he will develop a tolerance to it. So we want him to start, you know, having some contribution to the effect also from CBD.
So for this case, it's like no report of side effect or adverse effect from previous use.
Yes.
So I'm wondering that, so why he
Yes.
not continue for his use if like it's maintain his symptom, insomnia completely relief?
Yes, but there is also anxiety and pain and nausea that are not completely relieved. You know, and so you need to target also those symptoms in the day. I think he was just using the THC at night, correctly?
Yes.
Yeah. So we need to do something. I mean, it's obvious that you will not see a patient in your clinic that is doing fantastically, because nobody wants to fix something that is not broken. However, you know, when patients are undergoing treatments which are and are at risk of being exposed to products which are not pharmaceutically correct, we always try to switch the patient to, you know, a way that is legal and controlled.
We can do the follow-up now.
Mhm.
So we finished the first part of the discussion, right? But we still have the follow-up. So the case scenario, we still have the follow-up. So we need to do another group discussion outside, right? But we're a bit behind schedule now. So can we have the discussion for about 30 minutes? Would that be enough? Or half an hour.
How about
We can also go over the cases and then have somebody sort of suggest and go into that, you know, the next week.
I think we're going proceed to the second part, and each case they have second part, but the case that have third part, you just omit it, the third part, okay? And I think the best way is that you grab your coffee and go to your table, and we spend half an hour, right? Discussion.
So please return to this room at 3:30. And group 2 ready? Group 1 and 2. Okay, so please come forward to present your findings.
So for group 1, Mr. WD on the second visit, everything seems to be better. This is actually the month before a month after this he will be having stem cell surgery, and everything was improved: pain, appetite, nausea, sleep. He's been more active, but however the appetite score is still a bit high. But this is actually the first visit. The first visit, I think the O measurement was high. It's on the high end. But then on the second visit, everything was markedly improved, but the appetite still minimally improved. The score was reduced from 8 to 6. So we were thinking of having him, this is what we're going to do on a second visit. At first, we're going to monitor his efficacy of the cannabis and its side effects. We're going to stop the inhale route because that will not be allowed in the stem cell transplant unit, and we need to prepare him for that. So the alternative of this second treatment plan would be, we were thinking of using the spray route, but then however this route is not available in Thailand. So we will change him to the route of sublingual, combined of course, with high concentration. And however, the inhale one, he need to inhale it 5 minutes before meal time in order to increase his appetite. But for the sublingual route, it needs longer time for the effect of increasing the appetite. So it has to be 20 minutes before meal time. And we will make sure he stay away from the street cannabis. And of course, we will do the psychological, psychosocial depression, anxiety, whether he's still happy now, relationship-wise, work, family, and financial. That is all. Prepare.
And for group 2, women aim to improve appetite and reduce harm reduction. Last visit he used combined THC and CBD twice a day, 0.5 cc and 1 cc, and use street cannabis reduced from 6 to 2 joints. And then my group have 2 choice for Thai taste cannabis. Yes, and one is the one schedule and add sativa spray before meal. Yes, and the second is separate for add a TID. Yes.
ml twice a day, so a total of dose of 10 mg THC and 10 mg CBD per day. We faced a problem because so he was still using some hashish, but went down from 6 joints to 2 joints per day, and he was not using the dry cannabis from the licensed producer. So because he was asking for help and agreed to be followed at the cancer rehab program, we decided as a team to continue and ask him to stop completely. And because of the transplant coming in 1 month, so the plan was to increase the oil, but actually we used Nylon in Canada, but it was to increase a bit the oil to decrease his need to use dry cannabis and hashish during the day. So it's not really an easy case, and I can tell you after that I called the patient after the stem cell transplant. The things were going well for him. He was going back to work, going back to working out, and he was able to decrease his use of oil only to once a day at bedtime, but he was having difficulty to stop it, like trouble to to sleep and sweat at night if he stopped. So we decided to decrease it to 22 ml for 2 weeks and then to stop. Then it was good fine because he completely stopped the use of cannabis.
Any comments? So,
Get back to this story, cannabis, right?
I don't think he did. No?
I think he used it as a recreational, like over the weekend, but it was able for him to go back to work and to go back to training. He didn't stop completely his recreational use, but the things were going a lot better for him. And he was quite happy now to feel better to have finished his treatment.
So there will be a lot of comments, but for the sake of time, I think it's better that we, and then if we have more time, we can sort of come back to this case. This is an interesting case, no doubt about it, and there might be some nuances that it would be useful for your work. One thing that is important, as you noticed, we are not talking about dying patients. We are talking about patients that eventually are cured, okay, after the stem transplant. So medical cannabis has to be covering, the whole disease trajectory, not just the terminal phase. Okay. So should we then present as well? Yeah. Okay.
So next group.
So this is a summary of the group 3 and group 4 we have already discussed together. And remember our guys who have 72 years old and come with neuropathic pain at his feet and insomnia. So right now he has a follow-up at 2 months and found that pain is controllable. Maximum pain score was 1 of 10 and no side effects found. And problem at night about pain is very soft, so actually everything is fine. So moreover, there has history of rash 8 weeks ago, which started before we start any cannabis. So the rash is followed up with the dermatology, so we think it's fine. And after we started the cannabis, everything is controllable, the rash is fine. So in this point, we think cannabis helps and reach our target to control pain and control the sleep. So we're gonna go with this dose and then follow up again in 3 months, I think.
Okay, so as mentioned, now we have had to adapt this case at the use of a one-to-one product because Navion was not available, and we had initial improvement for insomnia. However, the pain persisted during the day. And was still incidental. What we did was to continue to gradually increase the THC CBD balanced oil. It's not. You are right. I mean, it's.
He was taking like 0.3.
that towards, well, in essence, I adapted it because of the absence of nabion, and also CBD-rich products. But what you say was correct. Yeah, because this is the, you know, the 125, this, yeah. Yeah. So I mean, the response were good because we used, you know, the CBD-rich oil during the day, but it was also increasing nabion at night. Okay? From 0.25 went to 0.5. Okay. So I kind of adjusted it, but I didn't adjust in a way that is really helping you to understand that. So that's, you know, optimization of the CBD-rich oil during the day and, you know, the nabion at night is what at the end worked for this patient, even though we don't have the follow-up visas for him. Okay. Okay. So should we go to the other?
Next group.
So is summary of the group, the fifth and the sixth group. According to our symptoms, is get better, so we decide to maintain our treatment and just follow up. The patient said that he improved good sleep and so all the quality of life got better, so do nothing.
So we kept the same dose at night of Capilano up to 0.5 ml at night, which is about 5.5. Yes? So the Capilano oil, you know, was increased gradually from 0.2 to 0.5 at night. Okay, so it's actual plan of treatment, you know, current cannabinoid treatment plan. And he was using the actual dry cannabis, which was a THC-rich type of sativa, and was using it before the meals. That to help with that aversion for food that he was having. Now, we don't have a dry product. It again could be a case where you could use sublingual with those sort of, you know, precaution that we need to give it at least 15 to 20 minutes before the meals, you know, to allow for some absorption of the product. And obviously, it would be better to have a product more concentrated to guarantee a real increase in the bioavailability of this product. So, however, what I can tell you is sometimes the patient reports an effect which may also be a placebo effect. Okay, and what can you say? You know, it's an effect. It's working. Why do you need to change necessarily? So the patient may say, well, it works. You know. Some patients say, if it works right away, which I know is impossible to work right away for a sublingual, but the patient is happy, that's it. You know, you don't really need to do more. Okay? Thank you.
Last, please.
for the LB, Mr. LB, after use the previous cannabis prescription is release pain, release insomnia, nausea, vomiting, and sleep. After use, the scale of pain and insomnia. Okay. In the previous, in 4 is decreased 3. If dryness is 5, it decreased to 2. Yes, and overall is better, but the well-being, the patient rating scale 10. Yes, I question the patient remind please miss. Yes.
Please. Yes, for the people in Quebec, when they say that you are top 10, is that you are perfect, that you do very well. And it's obvious that it could tend to say that he was top 10, but in reality it's 0 out of 10.
Overall pain is better, but in the third visit, this total symptom is very better. Yes. And doctor and nurse should remind the patient to start use cannabis. Regular use, avoid tincture cannabis. Yes, yes.
Mentioned is that he was taking only a dose in the morning, so 0.9 ml, so it's 9 milligram THC and 9 milligram of CBD, with a good effect on energy. Patient got back to train in the gym, better mood, but the symptoms are coming back in the afternoon. The pain is coming back. He reports no side effect. So the plan is to add the second dose of oil in early afternoon to extend the effect of the oil because of a positive effect in patient autonomous with the administration of cannabis we're following in 2 months. Then at the second visit, his SNBPL were stable, more energy and overall good well-being, no sleep issue. So he was currently taking 1 ml twice a day, so a total of 20 milligram THC and 10 milligram CBD total per day. We decided that it can increase, so we go up a little bit more than the maximum that we give because the patient was responding so well. And some still ongoing discomfort on the rectal area. So, and we follow him in 3 months. Then the third visit, you mentioned I've 100% relief with cannabis and no more nausea, still a bit of fatigue, no more anxiety. He was going back to the gym 5 days per week. So still fatigue during the 2 weeks of during the 2 weeks of the chemo pills. The sleep remained good because he was more active during the day. He didn't need any more finger for sleep at night because he was more active. So then we will see him when we go back in Canada for his 6 month follow-up because he reached a satisfactory symptom control, so we just decided to follow him in 6 months.
questions from the audience? I think we have one more session left.
Yes.
The patient education and follow-up, right? We still have one more important talk to close this, to finish this workshop. So Virginia will be talking to us about patient education and follow-up.
Thank you to all participants for your brilliant participation today. It was very nice. With collaboration. Objective, precaution and contraindication detected in the file review and in the interview. We ensure some precaution for the elderly patient or patient with renal or hepatic dysfunction. Then we review as a team what will be the best treatment plan that can best achieve the patient's objective, and that is safe and respect the capacity of the limitation of the patient. And always we start low and we go up slow, and we stay the lowest possible dose. So we are working on as a team towards the objective. So I like the thing on that. So after the initial consultation, that the big part of the nurse work, I go back into the room with the treatment plan that I prepared, that I handed to the patient, and I explain all the steps. So how to take the cannabis, so how to use the syringe, how to manipulate the bottle of the dropper, how to use a spray of dry cannabis, how to register with the licensed producer, the daily that the patient will have until be registered and having the authorization to order cannabis. We review the law, Quebec law for cannabis, what they can proceed at home, what we authorize, what to do in case of the side effect. Then we have the therapeutic contract, and the patient needs to understand that medical cannabis is not recognized as a medication. Yes, we encourage the patient to call, to email at any side effect and concern that we can have. And we review so all the general information on the cannabis with the patient, so the different routes of administration that are available. I review with them, so I will go a little bit faster because I think we spend a lot of time. So we review what are the symptoms targeted by THC, CBD. We review the difference with the patient, a little bit of the action, the difference between using dry cannabis or spray versus a normal dose of oil or a rectal dose. That is the same, the absorption. So all the treatment options are discussed, the price, the side effect, and the difference. We can review if the patient with the endocannabinoid system as well, and that they need to know that each person is different, and so that's why it's a personalized treatment, and it's trial and error. So after the initial consultation, the nurse educates the patient about the side effect, the progressive augmentation of the dose, how to titrate. We promote treatment plan compliance, promote autonomy in the patient, and the legal matters that we answer to. And we make sure too that they stop using the street cannabis. Physician part. So at Santé Cannabis, the nurse do the assessment and prepare a treatment plan, and then they review it with the doctor and confirm the treatment plan with the patient, and then the patient goes back to see the nurse for the teaching. So at Santé Cannabis, the follow-up is scheduled every 3 months, and they have a phone call follow-up from the nurse after 1 month. After 1 month, starting the cannabis. At Santé Cannabis, they do the appointment can be done by telemedicine, especially for palliative care patients. Some of our patients, we do a phone call conference too, sometimes if they are living far or are more sick, that's an option that we give to our patients too. At Santé Cannabis, they authorize the patient to be represented by the caregiver. So the caregiver comes to the appointment for the initial assessment and for the follow-up. So after that, they follow the patient every 6 to 12 months. And when the treatment plan is stable at Santé Cannabis, they try to refer as much as possible to the family doctor, the follow-up of the medical cannabis after that. But also the recurring physician. So at the NUH medical cannabis program, the nurse and the physician review with the patient the cannabis treatment, so we explain that, those cannabis product titration, at the follow-up, so what the patient is taking, and when he comes for the follow-up, we review that. We review if there were any changes in the situation, any change in the treatment, any change in the chemotherapy, or any change in the medication that we review. We update the medication profile and use the as-needed medication. So, for example, for the breakthrough medication, we always do at the first visit on average, if they use 5 breakthrough of morphine, for example, 5 milligrams per day, 5 breakthrough per day, we will ask them at the follow-up how many breakthrough per day now they are taking, and we will update in our note. We will review with the patient the side effect and the benefit of the cannabis treatment. We then propose changes to optimize the treatment plan. So evaluate if they need a readjustment in the dose or in the frequency of administration, if we need to reevaluate the objective or a change in the treatment plan. We review the legal matters and the follow-up. Then if the patient is not yet stable, we can follow him in 1 month, or otherwise going better, we can follow him in 3 months, and after that, when he's stable, we can follow him only in 6 months after the NUHC. Santé Cannabis, I think I already did it. The first month, the follow-up donors call the patient after 1 month. Santé Cannabis, they don't come to visit. And afterward, the follow-up are planned at the clinic every 3 months, usually. And in the following visit, the nurse assesses the treatment objective, the compliance of treatment, changes to optimize the treatment plan, manage side effects of the patient. So it's quite similar. Any question, comment? You need that I repeat something or?
There's a question for me.
What kind of cases that you would prescribe the rectal route of the cannabis and how you administer it?
So the rectal route, the patient will have either to do his own suppository with the oil, so we have recipe that we can give, so they have to do it themselves. Or otherwise they can use directly the oil in the syringe directly intrarectal use. So with the rectal use will be when they have too much nausea, vomiting, or cannot tolerate at all the taste of the cannabis.
And what is the dosage? Same as the oral route?
So, as I mentioned to others that had the same question, the rectal route seems to be a good choice in cases again where the oral route is not available, and also when you need to increase the dose substantially by mouth. That happens primarily in patients that try to take cannabis to treat their cancer. So they have to increase the dose almost by 10 to 15 times what is generally used for symptom control. Okay, and this is total unregulated, use of cannabis. So that is why the rectal route is seldom used in our sort of practice. Okay. Again, sometimes there is no alternative to the oral route. We use with caution the rectal route, but because there are not very good studies yet about the pharmacokinetic of this route, it's still a bit tricky to be reliable and predictable. Okay. So what the patient says, sometimes the patient asks if they can use the rectal route, and we say yes, but we discourage patients to use it in order to increase the amount of medical cannabis that they can take, because they want to use this famous Rick Simpson oil, or RCO, that you will find on the internet, that is sort of is proposed as a cancer treatment. But in general, the dose, if you want to transfer from oral to rectal, is the same. And also the administration times is the same.
Do you have any experience about the other patient group other than cancer?
Other than cancer, sorry, what?
Some dementia.
Dementia? Okay. So, yes, we have like elderly patients, and families are adamant to say that just using drops of specific type of oils, mostly CBD, sometimes CBD and THC, they see an improvement, primarily in the level of agitation. The agitation seems to be responding well. Again, it's not necessarily an approved indication. I mean, we don't really have studies to support benefit in dementia, but again, when there are no other treatments that are supposedly working, and the family is asking us to give a try, and this try works, we are continuing, So I have, patients that are 90, 92, 93 in bed, and they seem to be doing. At times they don't come to see me either. But the family does the telemedicine. They show, a patient in the bed that is smiling, that is, nice and quiet, and we have to say it's probably working because they are not doing any other thing than just giving, small dose of cannabis. So that is the experience that I have. But again, it's suggested to really use drops. So we are talking about, 1, 2, 3 drops, 4 drops, something really sort of, fraction of milliliters is not convenient because you are really using very, very small doses. So it's better to count the drops.
Are there any other questions? Because we're at the end of the workshop now. If you have any questions, this is the time to ask them. Okay, so if there are no more questions, oh yes.
We can summarize a bit because we had a lot of questions today about what will be the best option with what you will have in Thailand, and what will be the best option to start. So because you will have really a concentrated oil, as I understand, that you will measure by drop, and that you will use sublingual. So as we discuss, we think that the best way, because you will have the oil that 1-to-1, if I understand well, will be like in 1 drop you will have 1 milligram of THC and 1 milligram of CBD. So the best option will be, and the safest, to have the 1-to-1 oil during the day. During the daytime will be the safest way, because THC can impair and can be difficult to tolerate, and to use the THC at night too, that you can start at only 1 drop as well. So, and for elderly, naive patient, that you want to start only a 1-to-1 for sleep, and even at night it's okay. It's just that it's safe. It's safer to use it during the day. The 1-to-1 is better than the THC. In our experience, we use sometimes THC-rich oil during the day for anorexia, cachexia, but really tiny dose, and you go really slow, drop by drop. Dr. Vigano, you want to?
Yes. So, I mean, when you're talking about 1 milligram per drop, you're talking about a 40 milligram per ml product, which is double of what we have currently in Canada. So it's obvious that the more concentrated is the product, the cannabis is lipophilic, so it's well absorbed like metal, at the mouth level. But you need to have a good concentration, probably at least 40 milligram per ml, to use the sublingual route more effectively. I suppose the spray could also work, but again, that has to be probably verified by pharmacy to make sure that you're using the right way to administer to the spray. But these are still opportunities which should be not underscored, I mean, rectal route, sublingual route are all very good alternatives to the oral and to the inhalation. What we are still sort of missing a bit is good pharmacokinetic studies, for this preparation. But we know that, the sublingual route is in between the oral and the inhalation, more or less. And we know that the rectal is similar to the oral route, and, it could be, a good alternative to the oral. But again, we don't have, particularly for the rectal, still good evidence that at least clinically is interchangeable with the oral, and it can be used more effectively as well on a routine basis. So I hope that you are not more confused than you were when you entered this workshop. I am going to thank you very much for hosting this, and I see you very enthusiastic, so I think we are going to work well together.
Thank you so much, Dr. Antonio and to close the workshop, I'd like to invite Professor Sylvia to please deliver the closing remarks.
Before I give the closing remarks, I'd like to talk about, actually I should start from the morning, the objective of this workshop, because I think we come across of our patients who need and who want cannabis, and we could not offer them the knowledge, how to use it, how to maximize the profit, something like that. And also because of the cannabis evil, it makes, the misunderstanding for the patient, for the misuse of cannabis. So I think if we have, for my objective is that in the future we're going to set up a cannabis clinic in our hospital with like this. Maybe we don't have variety, but we have learned a lot from you. Even we got some knowledge and some format that we can apply to our clinic. And at the same time, I think for the format that screen the contraindication and screen the goal of treatment, if cannabis is not achieve the goal, then we need to educate the patient instead of let them use by themselves. And I think if we have a good, effective cannabis clinic, we'll bring the underground cannabis to be a good clinical practice. And I hope that, I think this is only just a very beginning. I think we need to have a continuing learning a lot. And Dr. Vigano suggested maybe in the future we could arrange like a video conference. What do you think? Maybe after this workshop, we go, and if you have cannabis oil, you're going to try to use it, and you might come across many problems. You could come back again. You could share us your experience. And I hope that maybe within 1 or 2 years, we're going to have maybe kind of cannabis to be used. Okay? ค่ะคอยดูสถานการณ์ติดตามไปนะคือที่ต้องการคือเอาคานาบิสให้มันขึ้นมาจากอันเดอร์กราวด์แล้วให้ชาวบ้านเนี่ยเข้าใจว่าเมื่อไหร่จะใช้มันไม่ใช่อัลเทอร์เนทีฟมันเป็นคอมพลีเมนทารีนะคะโอเคนะคะก็เหนื่อยมากเลยนะวันนี้ชอบDr. Vigano, Virginie, I would say that today is a wonderful workshop, and I think I can speak for all the participants that we have learned a lot, and the teaching method is very interactive. So we would like to thank you very much for your effort, for your knowledge that you contribute to us. And we think that this will not be the first time that you come to Thailand. You have to come back many times in the future. So everybody give Antonio and Virginie big hand.
Jandalit for your acting a wonderful